Hello everyone, today I will quickly narrate through the topic SLE and antiphospholipid syndrome. SLE is primarily due to type 3 hypersensitivity reaction. Factors for SLE are deficiency of early complement protein C1q, C2, C4 and presence of HLA-DR3. The clinical feature mnemonic is MD Swash brain. M stands for malar rash, which is photosensitive, erythematous and scaly. NE also spares the nasolabial fold. D stands for discoid lupus erythematous. S stands for serositis. In lung, most common is pleuritis and least common is shrinking lung syndrome. In case of heart, the most common is pericarditis and the least common is limb sac endocarditis. Most common involvement in SLE is musculoskeletal system. O stands for oral ulcer. Multiple ulcers are present in oral cavity, which are painless. In the aphthous ulcer are painful, but here the ulcer are painless. A stands for alopecia, non-scarring. A stands for synovitis, more than 2 joints involved, with no deformity or erosion. In case of rheumatoid arthritis, there will be deformities or erosion. It will be symmetrical. B stands for brain. Most common CNS involvement is cognitive defect, lupus cerebritis due to anti-neuronal antibody, and psychosis depression due to anti-rheumatology P antibody. R stands for renal, lupus nephritis, very important topic. Here in immunofluorescence we can see full house effect, IgG, IgA, IgM, C1q, C3c. Classification is also important. There are 6 classification: minimal mesangial, mesangial proliferative, focal, diffuse, membranous and advanced sclerosing. In type 4 type, it is the most common and most severe type of lupus nephritis. There is wild loop appearance without glomerular proliferation or light microscopy. A stands for anemia and I stands for immunological feature due to various antibodies formed in the body, and N stands for ANA positive. The antibodies are very important. ANA is the best screening for SLE. Anti-DNase high titers are specific for SLE, but most specific for SLE is anti-Smith antibody. Anti-neural, as discussed before, lupus cerebritis. Ribosomal P, psychosis depression. Anti-RNP correlated with mixed cognitive tissue disorder. Anti-Rho, anti-La, both are anti-Rho, anti-La, both reduce the risk of nephritis. Anti-Rho or SSA, it can also cause neonatal lupus. The babies are born with butterfly rash and bradycardia, congenital heart blocks. Antihistone is drug-induced lupus, and the anti-erythrocyte, antiplatelet, they are not asked that much. Antiphospholipid discussed later. Most common manifestation of different system involving SLE. Skin, there is photosensitivity. Musculoskeletal, it is the most commonly involved part in SLE overall. And among the musculoskeletal, arthritis and arthralgia are most common manifestation. Cardiac pericarditis, pulmonary pleuritis, brain cognitive impairment, renal is proteinuria and hematological anemia. And drugs causing drug-induced lupus erythematous is CIP-PITA. Remember the names, they are asked. The drug-induced is common in elderly, female is to male is 1:1, where it is young and 9:1. Drug mainly involve the skin. Renal and brain are rarely involved. Here in SLE any organ can be involved. In SLE there will be reduced C3C4, here you will get normal level. ANA will be common in both, but in case of SLE the commonly done test is anti-DNase DNA, and in case of drug induced lupus erythematous it is antihistone. Overall, most common cause of death in SLE is cardiovascular disease, but the mortality in SLE is so bimodal pattern. That means in early years, after diagnosis, the most common cause of death is active SLE, mainly due to kidney or CNS disease. In later years, more than 45 years, major cause of death is accelerated atherosclerosis, cardiovascular disease. In treatment part, all patients with SLE should receive hydroxychloroquine, but the drug of choice is steroid. Belimumab is an BAFF inhibitor used in lupus nephritis who do not show response to initial therapy with steroids. And interesting thing is, most autoimmune diseases are worsened during the pregnancy except rheumatoid arthritis, which is decreased during the pregnancy. Antiphospholipid syndrome is also important. If it is associated with SLE, it is called secondary, otherwise primary. Criteria, there are 2: clinical and lab. Among clinical, there is vascular thrombosis and pregnancy morbidity. In case of lab, there is 3 values: lupus anticoagulant, anticardiolipin IgG IgM, or and anti beta 2 glycoprotein A. Remember, it is anti beta 2 glycoprotein, not anti beta transferrin or beta 2 microglobulin. And one clinical criteria with 2 lab values at least 12 weeks apart is required to diagnose antiphospholipid syndrome. It is also associated with thrombocytopenia, TTP, HUS, and Coombs positive and hemolytic anemia. Treatment is anticoagulant, antiplatelet, hydroxychloroquine, and statin. Glucocorticoids are not generally used, but it is used in catastrophic antiphospholipid syndrome, which is a life-threatening, rapidly progressive disease involving simultaneously 3 or more organs. It is seen in very few patients. In next video, we will discuss about Sjogren's syndrome.